going to be mostly about the adrenal gland. Again, this will be more physiology than pharmacology. There will be some pharmacology here and there and some clinical things as we go through it. But a lot of this is basically physiology of what the adrenal glands are and what importance they have to the body. Many hormone systems are not essential for life. They might be important for life, but are not essential for life. That is to say, if you lose it, you die. But the adrenal gland is one that you absolutely have to have. So it has a very important clinical aspect to life. So we're going to focus on the adrenal gland as actually being several different organs all at the same time. And we'll talk about each one of those. Some homeostasis, that's the physiology that controls secretion here. And as I said, something about drugs. Now, the main principles here are that while we have one organ that we're talking about, actually we have a pair of them, they are actually two completely separate, distinct, independently. Each one is two separate organs, types of tissue. And my analogy about glucocorticoids, like winning $100 million in the lottery, glucocorticoid drugs are very magical, like opiates, and are very, very popular, and are prescribed a lot, depending on the survey, more than any other specific drug class. But they have and they are very effective and very wonderful, just like winning a lot of money. But they have a dangerous downside. Okay. The adrenal glands are located on top of the kidneys. As I said, we've got one of each. So each kidney has this structure above it. It's not part of the kidney, but it's located right by the kidney. This shows the circulation. And what's important to understand about this is that the adrenal glands, here you can see coming off the aorta, there are arteries that feed the adrenal glands from the aorta, but also the renal artery gives rise to arteries that feed the adrenal gland, and similarly there's venous drainage from the adrenals into the renal vein and also directly into the vena cava. Okay. So the importance of that is that in surgical procedures, a lot of times there's work done on the kidneys and it can damage the adrenal glands too. Or atherosclerosis and renal hypertension can appear, and this affects the adrenals as well. So they're sort of connected to the kidneys from a circulation standpoint. Now, as I said, the adrenals are two completely different organs folded into one. The outer portion is called the cortex. The inner portion is called the medulla. And the outer portion makes steroid hormones. And I talked yesterday about steroid hormones and how similar all of these hormones are in structure, meaning their synthesis is similar in the ovaries and testis and in the adrenal glands. And in fact, the tissue, the embryonic tissue that gives rise to the adrenal cortex is the same embryonic tissue that develops into ovaries and testes. Okay, so of course, the synthetic machinery that makes adrenal hormones is very similar to the ovaries and testes, because in fact the tissues are the same. In other words, this is a mesoderm type of tissue that gives rise to two different kinds of synthesis, one that becomes for the gonads and the other the adrenal cortex. Now, the adrenal glands of the fetus are very large, and I'll say something more about this later. That's because they are secreting a large amount of hormones in the fetus, and this is an essential activity for the fetus to be doing, for the baby to be doing. On the other hand, the adrenal medulla, which is the inner part of the adrenal gland, is not mesoderm tissue. It's actually ectoderm neural crest tissue. It's nerve tissue. It's secretory nerve tissue, and it's going to make the same kinds of products that the sympathetic nervous system makes, because literally the adrenal medulla is connected to the sympathetic nervous system. It's a secretory organ of the sympathetic nervous system. So this is nerve tissue. Now they each develop independently, but then as embryonic development, as the fetus develops, the outer portion, the cortex, sort of wraps around the inner portion, and it sort of looks like one gland after the baby is born. So here's a cartoonish diagram of what's going on here. This is the cross section, and this is the developing gonad tissue, and this part becomes the cortex. Here's the nerve tissue coming down, and that becomes the medulla. And if you look at it a different way, here's the medullary tissue. It says 8 weeks fetal development. Here's the newborn fetus. This is the medulla, and this is the cortex. But this, and I wish I could color this, this fetal cortex that I said is essential during the fetus to be secretory will disappear, and so at 1 year of age, postnatally, that little piece of tissue is almost gone, because it's not functional. Now this is a cross section of real tissue. So the medulla is the inner part here, and the cortex, the outer part, has 3 different layers. This is adult adrenal gland. It has 3 different layers. And I'll talk on each of these layers has its own synthetic product. So I'll talk about that. Interestingly, the blood flow, even though the adrenal gland is 2 separate kinds of tissue as from origin to develop, the vascular tree is one for the whole gland, and it starts, the arteries are always on the outside of the gland, the capsule, and the blood vessels are flowing inward, and this is the medullary region, and then they collect into veins at the inside. And here it tells what hormones are being made. So as the blood flows from the outside in through the adrenal gland, it's picking up hormones from the various cells that it passes. Okay. So what does the adrenal gland make that's all that important? One class of hormones are called glucocorticoids. It's called gluco because they have an effect on glucose metabolism. They have their own receptor, which is, depending on various parts of the literature, sometimes called a GR receptor, meaning glucocorticoid receptor, sometimes called type 2 receptor, as opposed to type 1 that I'll get to in a minute. This hormone stimulates glucose production in the liver. This is an important part of metabolic physiology that is somewhat poorly understood. But you know, we tend to eat quantities of food, and then the liver tries to store what we're not going to use at the time and then distribute that out later. A lot of that is carbohydrate that's stored as glycogen. But if you go any extended period, an extended period I mean 6 or 8 hours of not eating, which is like every night, your body needs to furnish some carbohydrate, then and the liver may run out or run low. So the liver has the ability to make glucose by reversing glycolysis, by reversing the whole TCA cycle. And the substrate for this is amino acids. And the substrate for the amino acids is, of course, is protein. So here's a system where the body is able to make carbohydrate energy, ATP, from a protein source. Glucocorticoids drive this. Now, to be clinical for a moment, the glucocorticoid drugs drive this. Oh yes. Would a tumor that makes cortisol? Yes. Would high levels of glucocorticoid drugs create a hyperglycemia? Yes. This is part of the danger of glucocorticoid. Yes.
So if you're giving glucocorticoids to a patient or you have a problem, are you worried about like muscle breakdown, muscle wasting, or is
Are you worried about what?
muscle breakdown?
Oh, absolutely. And I'll talk a little more about that. His question was, are you gonna, in fact, it's the opposite of androgens. Okay? Androgens, I told you yesterday, are anabolic and tend to build up muscle and prevent protein breakdown. Well, glucocorticoids are catabolic. It's the opposite thing. Now, this is important for a few hours at night, maybe. You can withstand this, no problem, but any excess amount is going to be a problem. So I'll return to this in a minute. Let me finish about what glucocorticoids do. Is there a hand up over there?
That's a question. What is the relationship between glucocorticoids and glucagon? Is it
The relationship between
the glucocorticoids and glucagon?
Glucagon?
Yeah.
Oh, well, there's no direct relationship, but glucagon stimulates glycogen breakdown to a large extent. It'll promote this a little bit, but the main effect of glucagon is on stored glycogen.
Okay, and this is more so for
Which means you're getting glucose, monosaccharide, from the polymer of glucose, which is different.
And so this is more focused on gluconeogenesis.
Yeah, this is to make new glucose from a non-carbohydrate source.
Okay.
The source being protein. So, the second thing that glucocorticoids do is that they suppress the immune system. And yes, the drugs are used in transplants and so on. They're also used in tumors or cancer of immune, like lymphomas and so on. And they do this by literally killing the stem cells in the immune system. One of my grad school colleagues has had a hugely productive career studying exactly how that happens. It's a system of actually nucleases and DNases and that is specific to the immune cells, not other kinds of cells, but the immune system stem cells like the thymus gland. But it's an important, it's probably important physiologically, but it's quite important from a therapeutic standpoint. Now, the third thing glucocorticoids do is that they suppress inflammation, which may sound like the same thing, but it's not quite. Inflammation is a cellular immunity that involves histamine release and various kinds of cytokines and prostaglandin metabolites and that sort of thing. This is, in other words, the kind of inflammation that's associated with autoimmunity, like arthritis, asthma, and so on. And as a result, glucocorticoid drugs, the biggest use of glucocorticoid drugs is for inflammatory conditions. It is very effective. It is very, very effective for chronic inflammatory situations. Okay, now here's the thing about the metabolic effect of glucocorticoids to stimulate glucose production. Here's glycolysis and all of that, and here it leads down to the TCA cycle, and there's an enzyme here called phosphoenolpyruvate carboxylase. You'll notice this is cyclical and the arrows go both directions, see? So you can make glucose going this way if you provide enough oomph, energy, to push it this way. But to do that, you need a lot of oxaloacetate and you need this enzyme. So guess what? Oh, darn. Well, I lost it. I lost something I had in here. Well, there's supposed to be something in here that I didn't bring over. I'm sorry. You can get oxaloacetate from amino acids. And what glucocorticoids do is stimulate this specific enzyme. Remember, steroids stimulate new message. New message means protein product. The protein product here in the liver is this enzyme. So the amino acids are pushed toward oxaloacetate and the reverse glycolysis called the gluconeogenesis. And this is very powerful because you don't have a lot of free amino acids around. So the body, if it needs to, will start to break down protein to get amino acids, which ain't good. And excessive amounts of glucocorticoid will cause excessive amounts of protein breakdown. I've consulted through the years with lawyers and so on involved in lawsuits to help them understand mechanisms behind all of this. The problem being that someone gets treated with a lot of glucocorticoids, or even worse, they self-medicate with a lot of, they find ways to get more than they should be having because it's all prescribed medicine. and they wind up with osteoporosis and bone fractures in the hip and so on at fairly young ages. And this is a lot of trouble, because you literally dissolve the body structure away in order to get more amino acids in order to feed this thing. Now this is just a summary of what I've been saying here. Glucocorticoids, for example, in the bronchi, all of the different things that are going on that result in inflammation are that are associated with inflammation are suppressed by glucocorticoids. For asthma, for example, a lot of the glucocorticoid is administered as an inhaled medication. So in other words, anything that you can think of that's involved with inflammation, the tissue inflammation, are systems that are actively suppressed by glucocorticoids. This is considered important in physiology. I've heard it said we couldn't function without our cortisol. That the air and everything that we're exposed to would cause so much inflammatory reaction that our bodies couldn't function. We'd be locked up with inflammatory reactions. Unfortunately, some people are highly sensitive, and so this medication is, more medication is needed on top of that. Yes?
I have a quick question. So regardless if you, excuse me, take glucocorticoids, if you have like a lot of protein in your diet, regardless of that, it will still stimulate a lot of the gluconeogenesis?
So if you have a lot of protein
Yeah, if you
that you eat, you mean?
Yeah, like to use for the amino acids for the, can you like balance
To some
the taking of
extent,
medication? Or?
to some extent that would work, but fundamentally the drug is making more glucose than you need when you do this.
Right, okay.
So people with a tumor that makes cortisol appear to be diabetic. It can drive that much glucose production to make you appear to be diabetic. That is to say, you're going to have a high A1C and you're going to spill glucose into the urine and so on. So yes, you could prevent some of that damage. That's true.
Okay, but like minimally.
Yeah,
Okay,
yeah.
thanks.
It's still not a good situation. I'll talk about that a little bit more later. Now, cortisol is stimulated from the adrenal cortex by pituitary ACTH. Okay. And it does this by stimulating the first step of cortisol synthesis. And the first step for all steroid synthesis is to take cholesterol into into the mitochondria of the synthetic cells. Cholesterol is the starting point for making steroid hormones. But cholesterol has to be transported. I said yesterday everything needs to be transported. Well, there's a transporter protein called steroid acute regulatory protein. And that protein is necessary to move cholesterol into the mitochondria. That's because the first step of making steroid hormones is an oxidative step. It needs molecular oxygen. So the enzyme is in mitochondria. And ACTH stimulates the production of that transporter. So that starts cortisol production. It's the only step of making hormones that's stimulated by ACTH. So let me go through now the homeostatic control of cortisol. I'm kind of a, I don't know, a straight line thinker, so I think in terms of boxes and arrows and things like that. I think that's probably an endemic problem with scientists, right? So the adrenal gland makes these hormones, and as I just said, ACTH stimulates that. ACTH in turn from the pituitary is driven by a hypothalamic hormone called CRH, corticotropin releasing hormone, comes from the brain, and also another hormone which is called antidiuretic hormone that is made by the brain, but it has another function besides the kidney. It stimulates the pituitary gland as well to release ACTH. So, in fact, cortisol is stimulated by the brain. And furthermore, stress, which I'll sort of illustrate here as a non-specific thing. In other words, anything the brain perceives as something it doesn't like. Stress also drives this process. Now, negative feedback to control this is exerted by cortisol on the pituitary gland and on the brain. And the important point to mention is that only cortisol does this. These other androgen and aldosterone products don't do that. But cortisol has the negative feedback suppressive action. So that keeps cortisol in balance. If cortisol level drops in blood, then some ACTH will come out. If cortisol levels rise or glucocorticoid drugs are high, it'll have a negative feedback and suppress ACTH. Now, cortisol is not secreted at the same levels all the time. And in fact, cortisol has what is called a diurnal rhythm. And diurnal means there's a peak of cortisol secretion once a day at the beginning of the day. And it declines throughout the rest of the day and is low at night. This is driven by ACTH, so that means the brain controls this surge, this secretion. What's important about this is that, and in fact you can see it here, the rise of cortisol is actually, one of the factors that controls it is light. So when you're sleeping, theoretically, it's dark as far as your eyes are concerned. And when light hits your brain, then you're going to get ACTH come out, and the ACTH will drive the cortisol surge. But you notice here that the rise starts before you wake up. And in fact, it reaches a peak really when you wake up. How does that happen? It happens because the brain develops a rhythm that's called entraining. E-N-T-R, entrained rhythm. It means that if you get up at the same time every day, or pretty much the same time every day, then the brain anticipates this. This is part of kind of our evolutionary development. the brain anticipates this and starts the surge of ACTH, which leads to the surge of cortisol that's peaking right when you get up. Well, how about if you work a swing shift? How about if you work third shift sometimes? That messes up the entraining. Brain has to become retrained. How about if you fly to the other side of the world? Sometimes I have people in the group who are from the other side of the world, and I ask, what happens when you fly home or when you fly here? And they say, oh, it's kind of tough for the first couple, 3 days to get your rhythms, whatever those rhythms are, to get them back in line. This is one of the rhythms. The body anticipates when you're going to get up and get going. So doing shift work, and especially if you're not doing it consistently, can be a real problem on the brain cycles. This is one of the cycles. Okay. Yes.
Is that impacted at all by light-dark cycle, or is it only impacted by your own willpower to like go to bed and wake up at a consistent time?
He's asking if it's impacted by light-dark cycles. Studies in animals show that it's the light-dark cycle. Okay, so if you take rodents, and rodents have the opposite cycle because rodents are nocturnal animals. If you study rodents, this entraining becomes locked in and then gets very much out of sort, and then has to get reacquainted. And of course, in animal rooms, the lights are controlled very strictly. Okay. So yeah, the major force is the light-dark cycle, not your physical activity. And also there have been studies on blind people, and that is, people who are totally blind, and they still have an entrained cycle, but interestingly, the entrained cycle is like 30 hours, not 24. But the brain still develops a cycle. Yes. Yes.
What about if someone wakes up really early and works out? Is there an effect?
No, I didn't hear the question.
If someone wakes up early, let's say 5, and goes to the gym, is there like an effect on the
What
cortisol
did she
level?
say?
If somebody wakes up early and goes to the gym, does that impact this?
Yeah, but the training is kind of set, you understand. So if you're of a habit of getting up at 5 a.m. compared to lazy people like me, the signal will go out earlier, sure. The brain gets,
So it just adjusts.
yeah, the brain adjusts to this, not quickly. So if you get up at odd hours, some days, it has to be, the brain wants to be organized. Yes.
So if we're like a cop that has rotating, day, night shifts, like every 2 weeks they switch, the brain trying to readjust it,
Oh,
so
yeah.
just stop it.
Yeah, and if you've ever done shift work or anything like that, work, not continual shift work. I mean, I know some, like nurses in the hospital and stuff who always work third shift, that sort of thing, but some jobs you work sometimes at night, and other times you don't, and you can get really messed up, and you're just not sure, your energy. See, this is, why is this happening? Because it wants to prepare your body for the day's activity. See?
Sorry, really quickly. Going off what she asked, so if someone were to work out immediately after they wake up, is that why maybe a lot of people who say they work out in the morning, they feel more relaxed because they're
Oh, yeah.
decreasing that cortisol right away?
Sure, because your physiology is providing your big boost of glucose
Right.
right now. See?
I'll see you tomorrow morning. Anyone?
And you'd say, well, how about exercising at night? Maybe the tank is empty. I don't know. Okay. Most, as I said yesterday, steroids are not soluble in water. But blood is water, right? How do we manage this? Well, we manage this by having transport proteins in blood. And all of these steroids, estrogen, testosterone, so on, they all have transporter proteins to which the steroid binds. And 99% of the steroid in blood is bound up to these proteins. So there's very little free cortisol. Of course, only free cortisol is going to be bioactive, right? Because only free cortisol is available to cells, or is available to be peed out or whatever. You can measure hormones like this in blood, but with the understanding that you're only measuring that you're measuring all of it, not just the free cortisol. You can do free cortisol. That's a tough assay to do. If you want to know total output, though, because of the levels vary so much throughout the day, you can measure in urine and get a total daily output. So, to be clinical here, and again, not only could you have a spontaneous excess of glucocorticoid from a tumor, either a pituitary tumor, that would be Cushing's disease, or an adrenal gland tumor. These tumors are not malignant. You would get a whole lot of cortisol put out, and it would have all of the predicted effects on the body. So a Cushing's-like situation will result in what you would expect. Person with hyperglycemia, hyperglycemia, a protein wasting or atrophy. The skin gets very thin, and that's because the dermis on your skin has a lot of connective tissue. Connective tissue is protein, right? And diminished immune function and all of that stuff, okay? Because the body's going to dissolve away its own structure to provide substrate for making glucose. Okay. Now, a deficiency of cortisol, that's called Addison's disease, is the opposite. You got someone with hypoglycemia, low energy. That surge is not there, so they can't get the motor running in the morning. And a generally weak kind of condition, that is physically weak condition. Yeah, cortisol also stimulates a surfactant in the newborn, so newborn babies, sometimes the right at labor and delivery, the mother will be injected with some cortisol, and sometimes when the baby's born, they will have an inhaler kind of thing of cortisol to squirt in the newborn baby's mouth in order to cause development of a surfactant that they need to have in order to start breathing properly. Okay. That's cortisol. The second group of adrenal steroid is called mineralocorticoid. Comes from a different cell type. Mineralocorticoids and aldosterone is the main hormone here. Mineralocorticoids are completely different. They bind to the type 1 receptor, okay? And the function here, the target function here is the kidney to reabsorb sodium. Now, steroids synthesize a protein. New message, new protein. In this case, the new message and the new protein is for the sodium potassium ATPase that's in the collecting ducts and the distal tubules. The effect of that is to promote, you remember you had a renal block, right? Okay, so you know about this. To promote 3 sodiums to be reabsorbed from the filtrate and at the expense of 2 potassium ions that are kicked out. So in fact, aldosterone does 2 things simultaneously. It raises serum sodium, it keeps it up, and it gets rid of potassium. So clinically, if you see a situation in which a person and you measure always when you do electrolytes and for serum chemistry, you measure sodium and potassium. And if you see that the sodium and potassium are going in opposite directions, that is, one is too high and the other is too low, that means mineralocorticoid situation. In other words, too much, too little, you can easily figure out how this is going to happen. If both electrolytes are too low, that's not a mineralocorticoid problem. That's holes in the kidney problem. But mineralocorticoids will cause high sodium or raised sodium and low potassium at the same time. And a mineralocorticoid drug or any kind of situation like mineralocorticoids will do the same thing. Mineralocorticoid absence will do the opposite. Can mineralocorticoid excess cause hypertension? Yeah. Because if you reabsorb a lot of sodium, the water will follow. Can you treat hypertension with a mineralocorticoid antagonist? Yep. That'll cause some sodium to be lost, but it'll raise potassium. Not necessarily what you might want. Other ways to treat hypertension. Now this is an essential function. If you don't have aldo or you don't have mineralocorticoids, your serum sodium drops quickly and you would not live more than a day or 2. In other words, this is a kind of a weakness of our physiology. We absolutely need to keep pumping that sodium back in. The kidney loses sodium too quickly, in other words. you understand how the kidney filters everything and then pulls back what it needs. The question is, does it pull back enough? Okay, so here's a cartoon of how this works. Here's sodium here. This is in the filtrate side, and aldosterone stimulates the production of the pump, and the sodium gets sucked out this way back into blood, and potassium goes this way. Okay. Now, there's a completely different homeostasis to control aldo, and I would assume you had this, at least a mention of it. Nevertheless, I'm going to go through it again. It's a little bit complicated. This is my linear thinking once more. So aldo supports the reabsorption of sodium, tends to elevate serum sodium, and it tends to kick out potassium, so it lowers serum potassium. ACTH will stimulate aldo, but the line I draw here is a dotted line. And that's because in the acute sense, it'll stimulate. In other words, if you took any of us and gave us an injection of ACTH, it's a protein hormone, so you'd have to take it intravenously. If any of us had got an injection of ACTH right now, our aldosterone in blood would go up momentarily, and sodium would go up momentarily, and so on. But there are other factors that control aldosterone that override this. So, a person with a pituitary tumor that makes ACTH all the time might have high aldosterone sometimes, but not much. It's mostly a cortisol problem, because other factors will kick in and restore. This is too important a system to not have redundancy. So here's the redundancy. You know about this one. The kidney determines the osmolarity of blood and releases renin as a result, more or less, depending on what's needed, which winds up with angiotensin II, and angiotensin II also stimulates aldo release, independent of ACTH. So the kidney itself is having an influence on electrolyte balance, hormonally speaking, I should say. Yes?
Is angiotensin II a more powerful stimulator of aldosterone than ACTH?
Oh, absolutely. That's kind of what I'm saying. Yeah, you want to know if that's a more powerful. It's more powerful because it's continually active. You know, again, in the acute sense, as I say, if you inject any one of us with ACTH right now, we get a nice little boost of aldo. But if you continue to give ACTH, that effect would be suppressed by, and I'll show you what that is. So, if you continue to increase, in other words, the homeostasis here that I'm showing you with this cycle, this is a powerful independent cycle. Renin, responding to electrolytes, releases angiotensin more or less, and stimulates ANG2, which stimulates aldo and so on, but this whole thing can be shut off if sodium gets high and extracellular fluid in the juxtaglomerular apparatus gets high. It'll shut off the renin, which will shut off the aldo release, okay? And that's more powerful than the ACTH. So this is the loop that really matters as far as the adrenal cortex is concerned. But in addition, potassium also has an influence on aldosterone release, okay? Remember, potassium is kicked out by aldosterone. So low potassium will have an effect on the adrenal glands to stimulate some aldosterone if potassium gets too low. So you've got a third system that can drive some aldo release. And high potassium should shut it off. Okay. So that's why you've got a double redundancy here. The renin-angiotensin system and the serum potassium system, both of which control aldosterone, and that's why the ACTH effect is less. Okay. That's the aldosterone thing. And aldosterone is fairly specific. It's not a metabolic hormone, doesn't affect glucose, doesn't affect inflammation, all that other kind of stuff. This is a different system designed for electrolytes. Yes.
Can you just go back one slide really quickly?
Oh no, can't go back on slides. Sorry. What?
It's you said high potassium shuts it off. Excuse me.
I'm sorry?
You said high potassium levels shuts
Yeah.
it down.
Yeah. Well,
Don't you have that high potassium levels?
So
increases
what would you? So what would you like to have happen here? If potassium is high.
I mean, right there it says that it
If
stimulates
potassium
it.
is high.
I would think that it stimulates.
If potassium's high, you want to stimulate some aldosterone to kick that out.
Okay, so it doesn't shut it off; it stimulates it.
Yeah. Now, you can wind up with a little bit of a problem here, because if potassium's high and you want to stimulate aldo, but you may not have a blood pressure problem as far as renin-angiotensin is concerned, so these two systems can fight here a little bit. So you can wind up with high potassium in a person, and they can't get it down. That's a good complex question. I have written that question for the National Board exam. I've written a lot of questions for the National Board. But that's a good point. Okay. The adrenal gland also makes androgens. Androgens, not estrogen. Androgens. Both genders. In fact, it's not exactly a reproductive hormone here. These androgens are biologically weak androgens. They don't make testosterone. Now, some of the hormone that's made could be converted to testosterone, and some of the hormone that's made could be potent enough to express a lot of virilization. So an androgen tumor in the adrenal gland could be virilizing in a female patient, okay? Because these androgens still do what all androgens do. In particular, they are anabolic, and secondly, they are virilizing. As I said yesterday, all body hair below the nose is stimulated by androgens in both genders. And in fact, but see, there's very little, as I say, very little testosterone or estradiol comes out of this. And in fact, the body hair that starts to appear in children as they're growing, especially on legs, little axillary hair, even a little pubic hair, can be result from adrenal androgens. That's clinically, the word for that is adrenarche, right here. This is not actually puberty. Puberty is when the gonads start to function. It's not the appearance of physical signs, it's when the gonads, ovulation starts or sperm production starts. So, some androgens appear in children, and probably in women, most of what would be called body hair is the result of adrenal androgens. That is, the ovaries don't make a lot normally. And of course, after menopause, the ovaries aren't making anything. So there's some adrenal androgen around. Now, another point, some of that adrenal androgen could be converted to estrogen. And this would be a source of estrogen in women even after menopause. Not a lot of estrogen, but a little bit of estrogen. And this is of concern in breast cancer, because breast cancer can appear in older women, even much older women. As I recall, Nancy Reagan had breast cancer. She was in her 80s. And these cancers are often estrogen dependent and are treated with anti-estrogen therapy. So you'd say, well, where's estrogen coming from in a woman that's 30 years past menopause or whatever? Well, the adrenal glands are still cranking out some androgen, which is converted to estrogen, at least at a low level, a tiny level. But tiny might be enough for a malignant situation. Men too, of course. So male adrenals are producing androgen too, and males can develop prostate problems too, and so on and so on. So the adrenal androgens are sort of involved. This is not a powerful, essential physiology here. The kind of hormone that's made is called, and I don't have it here listed, dehydroepiandrosterone is the main hormone product, and you will see ads for DHEA as a useful supplement of some sort, hormonal supplement, and because it's a natural substance, you'll find it in on pharmacy shelves and in what would you call it, nutrition shops, that sort of thing, as a hormone supplement that's supposed to boost your metabolism, and well, the whole theory behind this is that they're slightly anabolic. Okay, they're weak androgens. So you may see that DHEA. Okay. Real controversy about whether that's terribly effective or just a lot of hooey. Now, this is the thing about the fetus and the adrenals in the fetus. The fetal adrenal gland makes a steroid substrate that the placenta needs to make estrogen. And this is a very interesting symbiosis. You know what symbiosis is? When two organisms work together in an essential way to provide something that the other doesn't have. So what we have here is the placenta in the mother that needs to make estrogen, but the substrate for it cannot make. The substrate for it comes from the baby. So the fetus, as it grows, the adrenal glands start to function, and they make a steroid substrate. Out of DHEA sulfate, which goes to the fetal liver and gets hydroxylated, and then that passes to the placenta, the maternal side, and is converted to an estrogen called estriol. It has 3 hydroxyl groups on it. This is a very powerful estrogen made by the placenta. But this little box diagram shows you that the placenta cannot make estriol from cholesterol. It needs the substrate from the fetus. Estriol is measured in late-term pregnancies to monitor how the fetus is doing. Because if the fetus develops trouble and the substrate drops, then estriol levels will drop in the maternal blood. One of my former lives, I ran a clinical lab that measured hormones, and this was at a medical center, and they used to have some patients, unfortunately, very sad situation of ladies who would lose the baby in the last 2-3 weeks, and the baby appeared to be healthy, but then the baby died. And so what they do is bring these men, and there would appear to be a tendency for this to happen again and again in a certain patient. So they would bring these patients in, put them in a bed in the hospital, and do a serum estriol every day. We did. And as long as estriol levels stayed up, baby's fine. If that started to drop, because you want to keep the pregnancy going as long as you can. You don't want, prematurity is also a problem. So day by day by day by day, they try to keep the pregnancy going. So they measure estriol every day in these patients. And if estriol levels started to drop, that's not a placental problem, that's a fetus problem. And they go in then and get the baby.
Is that something routinely looked at
Yeah.
in every patient? Is estriol levels looked at in every patient or only
No, just the ones that have this problem.
just in
The miscarriage. So stillborn is the expression that's used. Very extraordinarily sad situation. Yes.
Is it always classified as a fetal problem if the estriol level is dropping? Couldn't it also be that, like, for whatever reason, once it gets to the placenta, it's not being made into estriol?
Could be, but that doesn't happen. Now, the placenta could tear away, yes. So you have to be watchful in that. but that's not likely to happen. And I don't know, I mean, it's been some years now, there's probably some research that has identified the reason for the fetus developing problems. But it's a fetal problem, and it tends to be, late in pregnancy. In other words, the baby is normal, appears normal anatomically, and so on. But this is an essential symbiosis that between the mother and the fetus. Now, when the baby gets born, that this whole process over here will stop because it isn't needed anymore. That little zone of the adrenal cortex that was making the substrate will shut down. The fetal adrenal is bigger than the fetal kidney, which is maybe no surprise. Fetus doesn't need kidneys until after it's born. Okay. Let me say some things here about adrenal steroids. I've already alluded to this. Adrenal steroids are very, very, very popular. And by popular, I mean sales of drugs for what I call the 4 A's of autoimmune problems. Okay, especially various kinds of arthritis and allergies. They now have a bunch of these new arthritis drugs. Problem is, they cost a ton. Adrenal steroids cost pennies because they've been around for 50 years. You'll find it in lotions and creams too, can't think of the name of the product, but it's 0.25% prednisone. Okay, so here are the kinds of drugs that are used. I showed you this yesterday. Prednisone, which is cortisone, 11 keto. You put double bond here, and that's a little more potent. And that's the usual oral glucocorticoid that's given once a day, twice a day. For all sorts of, I wouldn't be surprised if one or more of you have used this kind of medication at some point. Not to mention parents or grandparents even. There are potent glucocorticoids, much more potent, that are even more chemically modified. They're more potent because they're cleared more slowly. They're cleared more slowly because you retard clearance by the liver, right? And this is mineralocorticoid. Okay. As I said, these are pretty popular medications, and so I got a dozen of them listed, and there's more than that even on the market. The ones across the top don't even have trade names because they've been around for so long. They were around before trade names even were invented. But these, and this that I've got surrounded by the box, these are new glucocorticoids that are particularly used now for asthma inhalers. And you'll see this advertised on TV, not that any of you guys watch TV, I know you don't, studying all the time. But you'll see these commercials for asthma inhalers and products on TV, and these contain very powerful new adrenal steroids. They are not to be administered orally. They're supposed to have really a topical effect on the respiratory system. In other words, it doesn't go any further than the bronchi for asthma, control of asthma. So these are new, and they're generally available only in the inhaler forms. They can be abused. Okay, I did a thing for attorneys one time where a patient was getting 2 different doctors and 2 different pharmacies to fill the asthma medications, 2 different asthma products of these, so that they could take twice as much of the stuff. And they developed some bad side effects. Now, this is a kind of chart that you'll see around a lot. If cortisol is considered a 1, it binds to both receptors, mineralo and gluco. This is a comparison of the potencies. This is a comparison of mineralocorticoid potencies. You can see aldo is way more potent than cortisol. That has to do with receptor affinity. And this compares the duration of a single dose. You can see here, 1 oral dose of dexamethasone lasts several days. That's too powerful to be used as a routine oral dose. And this compares dose size. So 20 milligrams per day of cortisol is 5 milligrams of prednisone and less than 1 milligram of dexamethasone. And the dose difference has to do with how fast it's cleared from the body. This is the adverse effects. As I said, it's a metabolic problem. I've sort of been through all of this. So the strategy of giving glucocorticoids safely is what's called intermittent therapy. That is to say, on again, off again therapy. So you may administer something, try to taper the dose, keep it as low as you can, and then hope that the patient can go without it for a while and until the problem, because of course it doesn't cure anything. If this is an inflammatory process, all you're doing is treating the symptoms. Those are called, in the trade, those are called symptom modifying drugs, as opposed to disease modifying drugs. You're not actually curing the disease. You're not causing the disease to disappear. You're causing the effects of the disease, the symptoms, to be suppressed. So intermittent therapy is what's taken for people with chronic problems. But you always try to keep the dose as low as possible so that you can minimize this metabolic action. Now, the metabolic effect is not going to take place in one day. It takes place over days, weeks, months even. Okay. Just a little bit more here. Adrenal medulla. I don't say much about the adrenal medulla because, again, you've already had a neuroblock, right? So you know about the sympathetic nervous system. To state it simply, the adrenal medulla is where the sympathetic nervous system meets blood. Think about that. The adrenal medulla is an endocrine organ. The products are epinephrine especially, and norepinephrine. It kicks out a lot of epinephrine, which is not secreted by the sympathetic nervous system. And epinephrine's a little bit different from norepinephrine. But it has the effects on all of your alpha and beta receptors all over the body, including a lot of receptors that are not innervated. You should know that we have a lot of beta receptors, but we have some alpha receptors that are not innervated. That is, the sympathetic nervous system only goes to wherever the wires take it, right? It's all about wiring. But we've got these receptors in other tissues. So how do they get worked on? They get worked on by the blood, and the blood, that's this. And so here's literally what's going on. This is a cell in the adrenal medulla, and you've got nerve endings here coming from the sympathetic side. Now remember, the neurotransmitter here is acetylcholine. This is like a synapse, not the postsynaptic fiber, but the presynaptic fiber, which uses acetylcholine. Okay, so here's the cell in the adrenal gland. Nerves come into it, and on the other side, you've got capillaries. So this is literally, there are only a couple places where this happens in the body, where the nervous system meets the circulatory system. The other big area is in the brain. Right? The brain is an endocrine organ, kicks out all kinds of substances into blood. So the adrenal medulla does the same thing, but only for epinephrine and norepinephrine. Okay, so here's, and you know this synthetic pathway from tyrosine, okay, the dopamine and norepi, which the norepi gets methylated right here with PNMT, a methyltransferase, PNMT, and you get epinephrine. The same thing that goes on in the brain, except more, you got one more step. Okay, so what do they do? Well, this is, as I say, it's like the sympathetic nervous system, only it's through the circulation, but the basic responses are what you would expect. And you got some alpha receptor actions, and you've got beta receptor actions, and as I said, many of these actions occur through receptors that are not innervated, so you can have a broader spectrum of responses. One, for example, is bronchodilation here. So a lot of asthma medications include glucocorticoid and a beta-2 agonist, right? There is a tumor situation here too. This is not malignant, called a pheochromocytoma, in which a whole lot of epinephrine and norepinephrine is kicked out. And it has, again, you could predict the kinds of responses. This is another board question type thing. The board question would be to differentiate a tumor of the adrenal medulla. Where's the thing at? Here it is. A tumor of the adrenal medulla with what it does compared to a tumor of the adrenal cortex. because you bring in a patient with hyperglycemia, hypertension, a little bit of tachycardia, but not weight loss, and some tremor, and you do a CAT scan, and you find a little mass over one kidney. So you have to read carefully the diagnostic signs to decide. And so the question would be, what are you going to measure in blood or whatever? You're going to measure cortisol? You know, it's a multiple choice question. Okay. And that's it. I'm going to ask you guys that kind of question. I'm going to ask you guys, well, you're going to have your little cases, and you're going to have other kinds of questions to answer using sentences with verbs and everything. Okay, that's the dream.